Good morning. My name is George Minowata. I'm a volunteer physician for the MAVEN Project and your moderator. Thank you all for joining us today. And our friends at Cherokee Health Systems, who have served the communities of East Tennessee since 1960, for hosting today's session titled Dermatology Basics, Common Dermatoses with Dr. Wendy Huber. Dr. Huber is the former chief of dermatology at Kaiser Permanente South Sacramento Medical Center in California. She retired after more than 3 decades in practice. Throughout her career, Dr. Huber held several leadership roles, including chief of patient education. With that, Dr. Huber, the microphone is yours.
Thank you so much for that kind introduction. And then I'm going to share my screen here. So welcome, everyone. Good afternoon. I'm really pleased to be available to share this information with you today. What I've created is a case-based presentation. I hope you do take advantage of the CME that's available for it. And I have put in a lot of cases. So don't worry about writing things down. All the important information is in the slide deck that you'll be receiving tomorrow. And if we can't cover everything, you can review those later on in your leisure. The housekeeping items were already taken care of very well by our moderator. It had to do with the fact I have no disclosures and that you should take advantage of the CME that's available for this. So my hope today is that I can give you a lot of practical tips from the 30 years that I spent taking care of patients in clinic with respect to successful treatment and preventing recurrences of the skin conditions. And also I want to spend some time on the clinical features that I think are really important that can help you make a successful diagnosis. So first, I will be covering very quickly some topical medication basics and going through some tips on selecting topical corticosteroids. That is a lot of information, and I could actually spend an entire talk just on that topic. So what I've done is I've put a lot of additional things that I would want you to know in an appendix. And so I recommend that when you get the slide deck, you do go through the appendix because it has information on how do you estimate body surface area, how many grams do you need to dispense if the rash is only involving a certain area of the body, those kinds of tips that I think would be really helpful for you. So getting to topical medication basics, I think most of us know that the efficacy of any topical medication is actually due to the inherent strength of the active ingredient, but also the concentration of the active ingredient. But there's 2 other topics that affect the efficacy as well that I want to mention. And the first one is the location of application. So if you have a patient that has a rash on the face, for example, 1% hydrocortisone ointment is very, very appropriate for that area. And that is because the outer layer of skin called the stratum corneum is very, very thin on the face. And it's very easy for a low potent corticosteroid such as hydrocortisone to penetrate through that very thin skin layer. However, if we had a patient that presented with a rash on the bottom of the foot, for example, stratum corneum there is incredibly thick. And the hydrocortisone, if we give them that, is going to try to penetrate through, but it just can't get through the skin in sufficient concentration to affect the inflammation. Now, vehicles, I did not know a lot about even after my dermatology residency. And I didn't really think they were important. But I was a referral physician for my area for contact dermatitis during my career. And I became really, really interested in the allergenicity of various chemicals that are mixed in with the active ingredient. And so I do want to spend a little time talking to you about vehicles because they're very important. So the simplest vehicle, and the one that I prefer and like the best because it is the simplest, is petrolatum. And this is very greasy and occlusive. Things are mixed into it very easily. The active ingredients mixed in very easily. And it's not an allergen. So from my perspective, when we're giving a topical medicine to a patient with broken skin, it's really important that we try to use products that are not going to cause them to be sensitized and to develop allergies to things in the product. So petrolatum is not an allergen. Although it is occlusive, it is non-comedogenic. It will not plug the pores. And more importantly, it doesn't sting. And I have found that a lot of times patient compliance is really affected by how well they perceive the medicine goes on their skin in terms of, does it sting? Does it burn? Does it make me itch? And if you give them a product that winds up having these effects of stinging and burning, oftentimes they won't use it, or they won't use it long enough. Now, creams came in and have a role because they're not as greasy. And certainly, you can't slather petrolatum all over a scalp rash because it's going to gum up the hair. So creams were developed, and they're basically oils where water has been added to thin out the oil. However, anytime you add water, you run the risk of getting colonization of bacteria or fungi in the product. So then you have to add a preservative. And unfortunately, many preservatives are highly allergenic, and also some preservatives can be irritating in and of themselves. Now, for medicated creams, the companies have really done their due diligence, and most of the time they pick the least allergenic preservatives to put in the product. Typically, it's parabens. And then sometimes they'll add in polyethylene glycol, which is a synthetic alcohol. And I'm bringing all these points up just because you've now added some additional chemicals that the patient could get sensitized to if they're having to use the topical medication for a long time. It also can create stinging and burning. Now, my discussion on vehicles also applies to the things we recommend to patients for moisturizers. And a lot of times we recommend cream bases to patients as a moisturizer. And so in those products, the manufacturers really don't do as much due diligence for an over-the-counter skincare product. And they tend to add even more preservatives. Some of those are highly allergenic. Many of those preservatives have an odor. So then they wind up adding fragrance chemicals to try to mask that odor. And because they're not scenting the product, they don't have to say that the fragrance chemicals are present. So therefore, you now have a concoction that can really wind up creating some problems for people who could get sensitized to them if they use it for a long time. Next, we have lotions, oils, and gels. Lotions are really nice for hairy areas in the scalp. Oils are great on the scalp as well. Of note, oils have less stinging than lotions or solutions, and that's because they're primarily oil. They don't have all these preservatives and additional alcohols or fragrances added to them. Gels have a great role for acne patients. They have very greasy skin to begin with, and gels will oftentimes contain an alcohol. They're not very occlusive, so they go on nicely. They dry quickly. So the only thing with gels is they sometimes can cause a paradoxical stinging or itching sensation when they're applied to the skin, and some patients don't like that. However, if the patient has really greasy skin, they oftentimes will not notice that, like the acne patients. I like foams, but unfortunately foams are really expensive. They're great for scalp psoriasis. So if you do have foams on contract for patients, people will be really happy to receive those for any sort of lesions that they have on the scalp. And sprays I actually rarely used, and I don't tend to recommend them. They seem very convenient, but I think it's really hard for the patient to tell where they've applied the spray and also how much they've applied at that time. And powders definitely have a role for the moist fold areas of skin. So medicated powders that have antifungal, like nystatin or talnaftate in them, can be really helpful. The only caveat is if you've got a lot of maceration of the skin, because it's so moist, so you've got little cracks in the skin, if you put powder directly on the skin, it can kind of clump in the crack, and it can feel very uncomfortable to the patient. So I tend to use the powders once people's skin has improved. And powders are a good maintenance in those areas. So in summary, when you're choosing a vehicle for a medication, I really do recommend petrolatum-based, the ointment-based, as much as possible, rather than going to a cream-based for the reasons why we discussed. And then for over-the-counter products like sunscreen, skin lotions, moisturizers, I do recommend that you let your patients know there are products that are designed for sensitive skin. They'll be labeled for sensitive skin or for babies. And those are the ones that I recommend. The manufacturers really have done due diligence when they're creating those products to put in the least allergenic preservatives and the fewest number of ingredients, including fragrance-free ingredients in them as possible, because they really don't want people having a reaction to their products. Now, there is a thing with fragrance. There was an article about 10 years ago where people were investigating products that were labeled as fragrance-free, and it turned out they actually had fragrance chemicals in them. And the way the companies got around that was that the preservatives and other chemicals had a bad odor, so they were adding fragrance to mask that odor, but they weren't scenting the product. They weren't creating a perfumed product, so they could say that it was fragrance-free. So I always tell my patients to do an additional look at the ingredients, especially if my patients feel they have a fragrance allergy or sensitivity. Okay, so on choosing a topical corticosteroid, I think most of you are aware of potency classifications, but there's also a group classification that I want to draw your attention to. It's very useful to know about. So the topical corticosteroids are grouped by their chemical composition, and there are 4 major groups, A through D. So if you have a patient who comes into you and says, you know, I saw the dermatologist, I'm allergic to hydrocortisone. I'm sure it's hydrocortisone, and I need to have, you know, a product that I can use. You can look up hydrocortisone. It turns out that it is a group A corticosteroid. And any of the corticosteroids that are also group A, the patient can have a potential reaction to. So you would then look at the other groups and select a cortisone from those groups that's of the same potency as the hydrocortisone. So you will find patients sometime during your practice who do have a corticosteroid allergy. It's not super common, but it's common enough that I'm sure you'll see that sometime in your practice. Hydrocortisone typically is the one that people are most allergic to if they're going to have a corticosteroid allergy, but I've also seen people allergic to all the other steroids. Potency classifications, there are 7 classes currently. Class 1 is the very high potency, and back in the day when I first started practicing, I would tell people it was the Cadillac of the classes. Class 2-3 is high potency. An example of that is fluocinamide. Old brand name for that was Lidex. And then class 4 and 5 is mid potency, and triamcinolone is an example for that category. Class 1 through 5, those are never used on the face, groin, and the skin folds. So those areas of skin have a very thin protective layer. That stratum corneum is very, very thin. Additionally, in the skin folds, you have the added problem with moisture. Moisture will cause hydration of that outer protective layer. And when that is very hydrated, medications can really permeate through quite quickly to the skin. And they'll increase their potency because they're achieving higher concentrations inside the skin than they normally would. So basically, those are never used in those areas. I do want to mention that there is a product, generic, that is still available. Initially, it was a brand name called Mycolog, but now it's available as a combination of nystatin and triamcinolone. Oftentimes people have used this in the groin, and we've had a lot of patients come through our clinic where they have incredible stretch marks in the groin area. And you talk to them about what's been going on, and it turns out that they were given that product to use because they thought they had a little bit of yeast, and the doctor said it was fine. Nystatin was great for yeast. Triamcinolone would take care of the redness. And very, very quickly, within just a couple weeks of using that product in this very moist area, they developed stretch marks. So never give people a combination product like nystatin or triamcinolone, because especially we worry about where they may use it. So what can you use on those areas? You can use corticosteroids on the face, groin, or the skin folds from class 6 or class 7. And 1% hydrocortisone is class 7, and it does not require a prescription. And I do want to mention that prior to 1990, and I was practicing before 1990, 1% hydrocortisone was prescription only. After it went over the counter, I started having a lot of patients coming to see me for some facial dermatitis, and I would tell them, I'm going to give you 1% hydrocortisone ointment, and they were very upset because they would say, it's over the counter, it's weak, it doesn't work well. Or they would say, I tried it and it didn't work. And I was kind of surprised, especially those who said they tried it, it didn't work. And I would find out that, yeah, they tried it, which meant they used it once. Sometimes they had to hide the hydrocortisone cream and it burned and it was stingy, and so they didn't use it. So basically, I spent some time letting them know that this is a very strong medicine for the face, that we don't need to give them something stronger. It's just they needed to use it longer, or it needed to be the ointment if they were having stinging and burning. So I just want to give you that information. I think a lot of times people feel pressured to give patients a stronger product, for a facial dermatitis, but I think you really need to explore how they're using it, because the 1% hydrocortisone is very efficacious for the face and dermatitis. So some tips, I think you should become familiar with, obviously, the corticosteroids covered on your formulary. Being familiar with a couple of them within each class is a good idea. I do recommend the ointment base. And then a big principle with topical corticosteroids is the idea of tapering the product as the patient improves. A lot of times patients get explicit information like, use this product only for 4 days and then stop. And, patients can be improving a lot, but they sort of have their own arc in terms of when they'll clear. And it's a good idea to be tapering the corticosteroid rather than stopping it cold turkey. And I'll talk a little bit further about that. For chronic and recurrent conditions, that's where someone maybe has atopic dermatitis, they have a recurrent irritant dermatitis, something where they're going to be having to use a corticosteroid off and on. You always want to find the least potent corticosteroid that will still be effective for them, and also the least frequent application. And that's that idea of tapering to less often use. If someone really has an ongoing problem, you should also consider switching to alternatives, which could be the calcineurin inhibitors, if appropriate. A lot more information on the corticosteroids is in the appendix, so I suggest that you look at that. So now we're on to cases. And what I'm really hoping to do is give you a lot of practical treatment pearls. But I'm also going to be describing what I'm seeing and highlighting those clinical features that are helping me to make the diagnosis. And as I said before, there's a lot of cases. So, you may have some bonus cases at the end if we don't get to them, but don't worry about having to write things down because everything is in the slides. So I'd like to start with two pretty simple things that we see in the office. This is a young lady who came to see me for acne. And as she was going out the door, she said she was really concerned about seeing some color changes in her lower leg. And then this is an older gentleman over 60. And he said he was noticing kind of an ashy change to his skin. He hadn't really been having problems with skin before. So pertinent history for the young lady was that she had recently started swimming, but otherwise there was nothing different for her. So what I'm seeing is on her anterior lower leg are some fine white scales. It's hard to tell the extent of the involvement of the scaly area of skin. So then I would use the word poorly marginated area of fine white scaling with some hypopigmented linear lines. And if we really take a look at those linear lines, we can see that they're really small areas of fissuring of the skin. And significant history for her, as I mentioned, was that she had started swimming and she was also taking some showers. For him, we see similar changes, except now some of those little lines look a little bit hyperpigmented, maybe some hypopigmentation, and it's got a cobblestoning look appearance with lots of scaling. So I think we would all, and also for him, it is wintertime, and it's been about 2 months into the winter. He said he's been more cold than usual and has been really heating his home significantly. So I think we'd all look at this and know that this is dry skin. And so why am I spending time on dry skin? And the reason why is this is the skin's first cry for help. It's the first sign that the barrier layer that's protecting the skin has been breached and that the skin is losing water to the air. And if this doesn't get attended to properly, then you can wind up having significant progression to erythema, and you can have conditions that are much more difficult to control. So for our older patient, unfortunately, we tend to make less skin oils that disperse on the skin. So we're more prone to environmental triggers that can dry out the skin, especially seen on the lower legs and the dorsum of the hands. For the younger lady, she was taking a lot of showers after swimming, and then she also had that exposure to some of the chemicals in the pool water, which may have been encouraging some dryness as well. So typically when patients come in and are complaining, there are environmental triggers that are causing the problem. And we can see those here as pertinent to our patients. I have learned to ask patients what they're doing to make their skin better, because invariably people are doing things to help the skin. And I can't tell you how many times I found that people were using alcohol or hydrogen peroxide on their skin because they saw these little teeny cracks, and some of them look at it very closely, and they were very worried about infection starting. So the alcohol and hydrogen peroxide were counterproductive and further drying out the skin. People don't volunteer that they're putting alcohol in their skin, at least they haven't to me. So I just wanted to draw your attention to that. So the goals of the treatment is to restore that barrier layer, to get the oils back on top of the skin, to stop any of the fissuring, and to prevent progression to an eczematous process. So we're definitely going to have both patients try to avoid frequent hot showers. The hot showers are going to try to get too many of the oils off the skin, as would a bath brush or a loofah. I'm not a big fan of loofahs. They did a study within 1 month of purchasing a loofah and using it. There's significant bacterial colonization throughout the loofah. If someone wants to use that, they need to change it out every month. And then some people really like to soap areas of skin and scrub them where they see flaky skin, and they're worried about infection. They want to keep it clean. I'm not a big fan of soap. It's a really can, affect the stratum corneum too much. But if people want to use soap, they have a choice of plain glycerin soap, and health food stores sell that. You have to make sure no fragrance is added, though. And there are soaps, of course, for sensitive skin that are a soap substitute. I prefer just water for those areas, and I'll let my patients know that. And then we have to moisturize. So from my previous discussion, obviously an ointment base I think is great. And I like just plain petrolatum. The advantage to that is it's inexpensive. It works really well. And there's nothing else in it. Now, I tell them that get something that says petrolatum that's in a jar, because it turns out recently companies have been putting it in a tube, and when they put it in the tube, they added additional chemicals to it, which is sort of defeating the reason why I'm using it. Patients don't like the fact, though, that it's really greasy. So oftentimes they'll use it initially as their skin's improving, then they want to graduate to a better product or one that they like better. So then we get to the creams, and patients will typically ask me for some recommendations. And I tend to tell them types of ingredients that I think are most beneficial for them, and not specific brands, because those can change all the time or change their formulation. So products with dimethicone are generally well received by patients. They're very lightweight and they're non-greasy. And then 47% of our skin oils consist of ceramides. So some products decided to create synthetic ceramides. And there's lots and lots of skincare products with these synthetic ceramides, and patients like them. And colloidal oatmeal will also has been shown to improve barrier function of the skin. So that can give you some suggestions for your patients. Now, once those microfissures are improved a lot, some people still notice that there tends to be a little bit of a dryness to the skin still. It's not as smooth as they would like. And that's where products that contain lactic acid can be helpful. The strength range is listed there. And lactic acid will help to further exfoliate the skin so you don't have the scales. It will also hydrate the skin because it's a humectant. And humectants are chemicals that actually draw water from the air and hold it onto the skin. However, the lactic acid can cause some stinging and burning sensation, even on normal skin. So there are some people that don't like it. They're also fairly expensive. I tell a patient that you're going to see full effects from this product if you use it twice a day for 6 weeks. So if they're not seeing a lot of improvement at that time, then it's probably not worth the money. And then the big reminder for these patients, and this is where I've had some patients come into clinic to see me because once they were doing better, they just stopped doing everything. But as long as those environmental triggers are present, so as long as the patient is swimming, as long as it is winter time and our gentleman is in a warm room, they need to continue the regimen that we've given them. Otherwise, they're just going to flare up. So what happens if someone doesn't continue the regimen? Then we see a person who comes in with a rash like this. So this is an older gentleman. He had been trying to take care of his dry skin. He got busy. He never really liked any of the creams. They didn't care for the Vaseline. And he had been trying to put a little bit of lotion just in this area that had become more itchy over the last few weeks. He found that he was scratching a lot through his clothing. It was starting to bother him now when he was just first going to sleep. And what am I seeing? So in looking at this, on the lateral part of the lower leg, I'm seeing an ill-defined area of some significant white scales. And in between those scales are now these red linear depressions. And those are much larger inflamed fissures of the skin. So what we're seeing is disruption of the epithelium, which is a hallmark of an eczematous process. And also it's not really, I mean, it's really hard to tell exactly where this all stops and starts. And that's also a hallmark of an eczema or dermatitis. Now I have another picture of the same condition, but it looks really different. And here we see a lot of redness, and we don't see the flaking here, and it's really hard to see the fissures. And so this patient has been taking good care of their skin, and they wound up putting their medicine on and their moisturizer on before coming into clinic. The other thing I want to point out, because early on in my practice, I would have patients call me up. And so when you give them a greasy recommendation of either medicine or an over-the-counter moisturizer like petrolatum, it intensifies the appearance of the inflammation. So this patient without the creams and the ointment would look very much like this. But with the grease present, it really highlights the redness. And so early on in my practice, I had patients call me up and they would say, you know, what you've given me is terrible. It's made my skin so red. I'm sure it's hurting my skin, you know, kind of like, what were you thinking? And so now I make sure to tell people that, you know, my medication is going to make this look bright red. And that's just because it's the optical properties of how the light's reflecting off the skin, and it'll just make that redness look more apparent. But it is not creating more redness for you. It's not hurting you. Okay. So the treatment now, we have to talk to the patient about the rubbing and the scratching, and we need to stop that. Need to also make sure that they're not doing anything, you know, to try to get rid of any possible infection that they might think is present. I do mention melaleuca oil because I've had some really bad experiences with people using that. Many people get really sensitized to this product. They become allergic to it over a few months period of time. And I've been called to the emergency room to see horrific acute contact dermatitis from the melaleuca oil. Melaleuca oil does have anti-inflammatory properties and it does have antibacterial properties, but I really don't recommend patients using that product. But at this point, we have redness, we have erythema. Moisturizer alone is not going to get rid of that. So we then need to choose a topical corticosteroid. I think for this patient, all of these are appropriate choices. Certainly the high potency corticosteroid will work the quickest, but it also has the most potential to thin the skin if it's used too long and by the patient. So, you know, tapering is always important to talk to the patients about. I personally like the patient to put their medicine on first and then put on their moisturizer over the entire lower leg, over the entire areas of dry skin. The reason why I like that is because it lets the patient see exactly where they're putting the medicine, and it makes sure that they're not putting the medicine onto normal skin. I've had a lot of patients who wind up dispensing a lot of medicine on their hand and just kind of trying to slather it over their entire lower skin because they're trying to prevent new areas from coming. And so, you know, that's really inappropriate use of the medication. And so I'll really make sure that they're only applying it to the area that they need to. As they improve, the ultimate goal is to completely get off the steroid product and then just use the moisturizer. And then this is an example of a topical corticosteroid tapering suggestion. Now, at this point, I do want to bring up a really interesting study that kind of lets us know why, or gives us some ideas why people may recur if they stop the corticosteroid too soon. So they did a study on patients that had had dermatitis on the dorsum of their hands. They cleared the dermatitis, and they waited 1 month after the clearing to do a biopsy of the skin. So we've got skin that had had a dermatitis. It's been totally clear for a month. They do a biopsy, and they see that there's inflammation still in the skin. At 2 months, they do another biopsy, and they see there's still inflammation again. And it wasn't until 3 months that the inflammation was really starting to recede. And so in my experience with many patients is that I think an inflammatory cascade really gets established in the skin, and that it's really easy for environmental triggers to keep that cascade going. So if you knock it down with a topical corticosteroid, it's looking really pretty good, and then they totally stop the topical corticosteroid, oftentimes that, and then the environmental triggers are present, then oftentimes it'll just break out right away. The patient will say to you, the medication didn't work. I mean, it did work, it's just, it wasn't there long enough. And I think that's really the big concept to get in terms of the reason to be tapering corticosteroids, which would include, if I gave this gentleman, for example, if I chose to give him the fluocinolone ointment, I really don't want him to use that too long. So I might have him call me up in about 2 weeks, let me know how he's doing. If he's doing a lot better, I might then switch him to 1% hydrocortisone ointment over the counter to be using twice a day to begin with, and then tapering that every other day, maybe every third night, that type of thing. Because that way I've ensured that he's on the least potent product that can still help him to continue to be successfully going to just moisturizers alone. Any questions at this point? Because I know I've been going kind of fast. Okay, if not, this is what we want to avoid. So this is someone who had seen me for dry skin in the past, had been given some medications like triamcinolone, ran out of medicines, was very stressed, wound up scratching a lot due to the stress kind of unconsciously. And then he presents saying that over the last week, he's noticed increased redness of his areas of dermatitis, and he's now noticing that his clothing is sticking to his skin, and that there's all these honey crusts as well, and his skin has become a little painful. So what has happened now is we have a much more significant dermatitis. What I am seeing are honey crusts. I'm seeing a pretty well-defined area of erythema now, and I'm seeing a lot of oozing and large eroded areas of the skin. And so we've got a dermatitis that has now become secondarily infected. For this particular patient, I would be giving them 1% clobetasol ointment. And then I would probably give them oral antibiotics. In my facility, we didn't have as much MRSA as perhaps others, so I would be giving dicloxacillin or a cephalosporin. Some people might try a topical antibiotic such as Bactroban or mupirocin, and that could work fine. I'm just telling you my preference. Oral antihistamines you could consider as well, but I think the medications would work pretty quickly, so we might not need that. This is another example of a dermatitis that became impetiginized, and you can see once again we have pretty significant erythema with areas of crusting and fissuring. And then there are some little satellite sites happening as well. I think you could get by with a topical antibiotic for this. And I'd probably use a high potency corticosteroid because it looks like the skin's a little thinner. It may be the flank or the lateral hip. So something like a class 2-3 topical corticosteroid could be fine. So this patient, we're seeing a lot of areas where there's erythema, there's some heme crusts, there's varying degrees of redness with the lesions on the right leg. And so this patient had a dermatitis that then got secondarily infected as well. For this patient, if he had similar lesions, on numbers on the back of the legs that we can't see and on the thighs, I would be considering a burst of prednisone. And typically I would use prednisone 40 milligrams a day for a week and then taper it over 1 to 2 weeks, depending upon how long I felt I wanted them on some oral corticosteroids. Oral antihistamines that are over the counter are fine. You might consider giving something that's a little bit more sedating at nighttime, depending on the patient's age, if that's appropriate. Okay, so, and I would be giving for this patient, like I said, the prednisone burst. Now, let's say it was just a smaller area, then I would use the class 1 topical corticosteroid, but I think there's just too much surface area involved here for that to work as well as I'd like. So what happens if you have a patient who can't afford a class 1 topical corticosteroid and all they have is a hydrocortisone or a triamcinolone? How can we increase the potency of those? So there's a couple things you can do that are around that concept of occlusion. So anytime you occlude the skin, you're retaining fluid and sweat on the top of the skin, then you're going to hydrate that stratum corneum layer, which then allows the medication to penetrate through. And so this gives you some ideas for occlusion. So you could, if the patient had a significant rash on the hand, all you had is the 1% hydrocortisone, you could have them apply that to their skin and then put on a glove over that and wear that overnight. And that will increase the penetrance of the product into the skin. Typically, if you're wrapping the skin or wearing the gloves, we typically have people not leave it on more than about 8 to 10 hours. And then I was taught never to occlude the skin for more than 7 days. And you must never occlude an active infection. So if you suspect an active infection, do not occlude that skin. There are other problems with occlusion, which one of them is you can get an inflammatory folliculitis on the lower legs. So it's just good to be aware of that. And then damp wraps can be really, really helpful. And back in the day before we didn't have so many new and wonderful products to treat severe psoriasis, for example, erythrodermic psoriasis, which is like total body redness, we would have people use a mid-potency topical corticosteroid over all the red areas of skin and then put damp clothing on top of that. And people did well with that treatment. So just some tips if people aren't able to afford certain products. Okay, so this gets us to a skin finding that I hope you guys have seen, and hopefully many of you know what this is. But if not, hopefully you'll feel comfortable with seeing this and understanding what it means after this presentation. So what I'm seeing at this point is kind of spotty areas of erythema, but the most significant finding is that we have marked lines, accentuation of skin lines, the horizontal and vertical lines, that's really, really apparent. Another picture. If you start at the bottom of the picture and look up, you can see that there are these nice thickening of the skin lines horizontally and vertically. We march up the skin with that, and then on the inner surface of the wrist, we can actually see that there's sort of a pebbly look to the skin, like the skin looks a little thinner in between, thicker in between the skin lines. And then there's some little focal erosions as well. All right, yet again, when you look at your arm, you don't see your skin lines like this. This is really prominent skin lines, and really that's due to thickening of the skin. So in all of these cases, we're seeing skin thickening. So what has caused that? Next patient, another marked case. Again, we see those kind of crosshatched skin lines at the base of the neck. There's erythema, there's one erosion. Some people might think that this looks kind of edematous, but if it's edematous, you wouldn't see skin lines at all. You just have a big smooth area. If you were to feel the back of the skin, it would feel firm. So this is called lichenification, and it's really, really important to pay attention to this. It comes from chronic, primarily rubbing, not necessarily scratching from the skin. The chronic rubbing will cause the skin to thicken. And sometimes you can see this as hyperpigmentation or hypopigmentation of the skin as well. Now, the interesting and the sad thing is that thickened skin is itchy skin. And oftentimes it's itchier than whatever started the patient to rub the skin in the first place. And so you get this horrible itch scratch cycle, which is really, really hard to interrupt. Now, when you see this, that is a clear sign that this has been going on for a long time. It takes, many, many weeks for you to get significant thickening of the skin. Now, a lot of patients don't want to admit that they are rubbing their skin. I think they feel kind of embarrassed that they're touching their skin a lot, and oftentimes they don't volunteer that. And it's really, really important that you and the patient become aware together that they are touching their skin a lot. So what I've learned to say to my patients that present like this is I'll say, a lot of patients I've seen in my clinic, have had skin that looks just like this. And they've wound up telling me that they find that they're touching their skin a lot, that they're kind of rubbing it and they're not aware of it. And, do you find that that happens to you too? And most of the time people will go, oh, yes, this is happening to me. I can't stop myself from touching my skin. I don't know what to do about it. So that's an important place to get with the patient. And then the next thing I will tell them is that there is absolutely nothing I can give them. There's no strong super medication that I can give them that will help this get better as long as they keep touching their skin. Let's put it that way. So there's nothing I can give them that will make them better unless they stop touching their skin. And sometimes people kind of look at me a little bit baffled. And I do like to make you aware of an interesting study they did of people that had normal skin on the top of their hands. They wound up drawing a circle on the top of the hand for these people. They asked them to lightly touch that area of skin in the circle for 5 minutes, and they wound up doing it 5 times a day, just lightly touching the skin, not pushing hard, not scratching it. In 3 weeks, the skin had become itchy and it had become red. So this is with nothing happening to the skin. There were no new moisturizers, nothing. It was just touching the skin. So sometimes that has helped my patients to really understand the role of the touching. Now, it took a long time to create this, so it's going to take a long time to go away. So typically, you're going to have to use a little bit higher corticosteroid than you normally would. Most of the time, we don't see this a lot in the skin folds. In fact, I don't think I've ever seen lichenification in the skin folds because the skin, I think, is too moist. You'll tend to see maceration instead. But you can get lichenified areas on the face that we'll talk about. Basically, if the patient is... So if I'm using, let me go back to this case. I think this is a good example. So for this person, I would be using clobetasol, a 1%, not 1%. I'd be using clobetasol ointment twice a day for a good 3 weeks. And then I'd have the patient give me a call, let me know how they were doing. If they were not doing that great, I'd have them use it twice a day for 4 weeks. And then at that point, I would try to see if they're doing better, if perhaps they could taper. Tapering would be then using it just once a day at night and then using it every other day. And what will happen is they should be able to taper continually off that. If not, I would do the clobetasol for a full month. I would try the tapering, and then if that wasn't as successful as I thought, I would switch them down to maybe triamcinolone and have them continue that for some more weeks, because it is going to take a while to stop that inflammatory cascade in the skin. A lot of times clobetasol says don't use longer than 2 weeks. So that's one reason why I wanted to let you know in this particular case, using it longer is fine. So let me go back here. We talked about this, talked about that. Over-the-counter antihistamines for the first week or 2 can be good. Certainly all the treatment recommendations we have for eczema are pertinent. You're trying to moisturize the skin is good as well. And then sometimes you have to use occlusion. So I have time, I think, to just discuss briefly. I had a case of an airline stewardess who was very stressed at work, and she would find that she was rubbing her skin a lot on her forearms. It was very embarrassing. In the summer, she couldn't wear short sleeves. So long story short, I could not make her better until I wound up occluding her skin with Uniboot material. And it wasn't the Uniboot material itself, it was just the fact that we had the triamcinolone on, we wrapped it with the Uniboot, and then she just couldn't touch significantly through the Uniboot. So that worked really well for her. With the Uniboot, though, it did dry out very fast, and she found that she needed to change the dressing quite often, a couple times a day, because when it was too dry, it was irritating. But that totally cleared her up. But prior to that, everything else I had been doing did not work. Okay, so now we're going on to a set of cases with the category of eyelid dermatitis. And the reason why I wanted to go through those cases quickly is the fact that 25% of the population will present in clinic with an eyelid dermatitis. This is acute contact dermatitis of the eyelid. And the way that we know that is the amount of edema. The patient's very, very itchy. And then if we're looking at this, a clinical finding to look for acute contact allergic dermatitis is these little bubbles that are kind of just below the eyebrow. There's little clear fluid-filled vesicles. And those are a sign of acute contact dermatitis. This person needs prednisone. And I have seen people with a presentation like this from ant spray. They weren't spraying their face, they're just spraying for ants, and they were allergic to ingredient in the ant spray. People can also have this presentation if they've been exposed to poison oak on some logs that they're burning in a campfire. That can create this as well. Another example of acute contact allergic dermatitis. And again, there are some tiny little vesicles that are present that are fluid filled. And I would tend to give this patient a course of prednisone as well, although they probably could get by with a slightly shorter taper than the first individual we saw. So most common causes of eyelid dermatitis is allergic contact dermatitis. Certainly you can see people with seborrhea, where the flakiness of the eyebrow area extends down onto the eyelids. And then there's irritant contact dermatitis. Irritant contact dermatitis is more likely sometimes from cosmetics that have glitter, like glitter eyeshadow, or they have mica in them, because those can be quite irritating to the skin. And again, this is where you might see a presentation of hydrocortisone allergy, because it is over the counter. People might use it for a rash on their face, and it may be that they, were already allergic to the hydrocortisone, or they sensitized themselves in using it for a dermatitis, but it is rare. This gives you a whole list of the really common causes of contact dermatitis. I draw your attention to second from the bottom, which is the artificial gel nails. This is pretty common, actually, so it's something to be aware of. Their gel nails are created from chemicals that need to be cured, and then they bond together. Not all of the the ultraviolet light cures them, but sometimes there are uncured elements left on the surface of the gel nail, and those are allergenic particles, and they can create a dermatitis like this. So this was from the patient's gel nails that they had recently started wearing. And what we're seeing is a pretty well-defined area. A lot of times with contact dermatitis, we think of things being well-defined, where the product is coming in touch with the skin. And so we see a little bit of erythema. 1% hydrocortisone is perfectly fine for this. Other considerations in terms of differential diagnosis, if this patient had psoriasis in other areas, this could be psoriasis. Typically, though, psoriasis isn't as itchy as a contact dermatitis. So this person removed their gel nails, had the 1% hydrocortisone, and cleared up. Okay, next three cases. Hopefully, when you are seeing this, what pops out at you is lichenification. So we've got a very well-defined area, we've got some scaling, and we have these markedly thick skin lines. Similar findings here. Lichenification, I feel, is really evident in the medial aspects of the upper and lower eyelids. There's hyperpigmentation, which means that it's been chronic. And again, we see lichenification because we shouldn't be seeing all these skin lines up by the eyebrow and below. So in the interest of time and moving on to other cases, I just want to let you know that I'm not, for all three of these, not sure what triggered the dermatitis. Whatever it was, though, by the time I saw the patient, was no longer in their environment. And it turned out that these patients, all of them, only had lichenification from rubbing. There was no further inciting problem. And the thing that I found troubling was the fact that they had been dealing with this so long, with the thought that there was something in their environment that was continuing to bother them, and there wasn't. So all of them improved when we could deal with them not touching and bothering the skin. My last mention on lichenification is the fact, especially if it's on the eyelids, a lot of people find these flakes very upsetting and they will try to peel them off. And I think that's one of the reasons why they continue to have the dermatitis. So I tell them that instead of peeling them off, they can put Vaseline on as often as they want. And that can be very helpful for them. Lots and lots of tips on eyelid dermatitis and treatment that I'm going to let you peruse after this talk. And I just wanted to show this case. So this is that seborrheic dermatitis. You could see how it could extend onto the top of the upper eyelids as well. But we're seeing just some kind of ill-defined areas of flaking and scaling. Seborrhea has all those traditional areas of involvement, the hairline and the nasolabial folds. Medicated shampoos. My tip for seborrheic dermatitis is to have the patient get the over-the-counter shampoos of 2 or 3 different active ingredients, find the products that they hate the least, and then to rotate them. So one week they use one active ingredient, the next week the next active ingredient. And when things are active, I have them use the medicated shampoo every day. Once it's better, it goes down to 2 times a week on an ongoing basis. Choices for the erythema I've listed here for the scalp and for the face. Typically, we don't like people to be using corticosteroids continuously on the face. They can develop a rosacea. And there are other medications you can consider that are not corticosteroids. They don't cause skin atrophy. And I draw your attention to the pimecromolus because that one is very excellent, can be used on a long-term basis. The only thing, it doesn't work quickly. So sometimes giving someone a short course of a topical corticosteroid for facial involvements of the seborrhea and then going to this calcineurin inhibitor can work quite well. Blepharitis, you're probably all familiar with. That's the greasy scales from seborrhea on the eyelids. This is a treatment that's recommended for that. And then I wanted to draw your attention to a new presentation or newer presentation of seborrheic dermatitis that can look very unseborrheic-like. And there is a differential diagnosis for this, which is tinea corporis lupus, secondary syphilis, to name a few. This is what it looks like. So it doesn't look like seborrhea. It's in the typical seborrhea areas, but it's these annular plaques. These, in this case, they're slightly hypopigmented and the border looks a little raised. In this one, we do see annular hypopigmented plaques with a little bit of a raised border as well. Certainly have to consider lupus. And you can see that a little biopsy was done up here in this corner because the practitioner wasn't sure what they were dealing with. So just to be aware of this, and this isn't just in, this can be in young people, old people, doesn't matter. On to this case, hopefully all of you will recognize this after seeing a few more pictures. Basically, the patient said it's not particularly itchy. A lot of patients will notice this more when they've been out in the sunlight because that's accentuated it. What I am seeing are coalescing, scaly, in this case, hypopigmented papules, and this is tinea versicolor. And so the big thing about tinea versicolor is that the fungi that's causing this actually affects the melanocytes, which make pigment on our skin, and they cause them to not make the normal amount of pigment. So when a person goes out into the sun and they're tanning, it will accentuate the rash. And I've had a lot of young men come in saying, oh my God, I was out on the beach for a couple of days and then this rash started and people think I'm going to give it to them. Am I contagious? The thing you need to look for when you're seeing anything like this, especially this one, is you need to see if there's scale, and you want to determine that right away. I will take a 15 blade or the edge of a slide and lightly abrade the top of the skin. And if I see scale, then I know that I'm in the right diagnostic kind of area. And then the most important thing to do is to additional pictures. And you can also see that it can be a little bit pink and even can look red. But again, these have scale present. And I'm going to do a KOH in the office, and I'm going to be looking for spaghetti and meatballs. And this is a typical thing for that. One aside, and then I'll see if there's some questions, is that the spaghetti and meatballs thing takes a long time to figure out on a KOH. So it took me 3 years, I think, of looking at KOHs almost every day for me to be able to recognize this all the time and not be confused by clothing fibers or from extra skin lines that hadn't dissolved yet from the KOH. So don't feel bad if you have trouble with these. Keep trying to get good at them, but they're really, really helpful in making a diagnosis. My favorite treatments are listed here, which are topical treatments. I like them because they prevent recurrences. I do not think prescription products work any better. Selenium sulfide, though, is prescription only. So that prescriptions you do need to give, because the over-the-counter selenium sulfide will not work with this regimen. It's not strong enough. There is systemic treatments that are available that I'm listed here. And what suggestions on preventing recurrence. Of these, I do the selenium sulfide shampoo to prevent recurrences. You have to tell the patients, unfortunately, it will take a long time for the color to normalize. And this is a caveat for you that there is a differential diagnosis to consider, especially if your KOH is negative. So I've listed that for you here. And I think that kind of takes us to hopefully this last case that I just want to talk to you about the highlights in the history that give us the diagnosis. So this is a young boy, very itchy spot, has been present for a couple weeks. It's growing. It started out being pencil eraser size. What I am seeing is an annular plaque with a very, very raised border and an erythematous rim. And of significance is the fact that the center is clear. This is tinea corporis. It can be one spot or many. Another example of tinea corporis. Hallmarks of the history, an expanding lesion. The center is clear. Oftentimes there's a history where they've been adopting a cat or they're playing with stray cats. And then that border is where you want to scrape. That's the active expanding lesion. Do not scrape for a KOH or a fungal culture in the center because that is a clearing area. If you see little vesicles, that's a wonderful place to scrape. The roof of the vesicle will be loaded with hyphae. And I have a lot of comments here and further pictures of sort of tinea corporis, including this. And I have a section on inner trigo, which will give you lots of tips to help the patients improve their environment here that we're seeing underneath the breast area. Because if that environment is not attended to, you will be seeing this patient over and over again. And the rest of my slide deck sort of talks about that. So I don't know if there's any questions, and I thank you very much for your attention, and I hope that you got some treatment pearls from this presentation.
Thanks, Dr. Huber. That was a lot of information.
I
We
know.
have a number of questions in the Q&A box. Let me just run through some of them. What are recommendations for a baby with atopic dermatitis and not responding to triamcinolone?
Oh, that's a hard question because first of all, I need to know more about that's kind of like an offline question, unfortunately.
Okay.
Gosh, I don't even know where to begin with that one. I'm happy to talk to someone afterwards if they like. That's fine.
Okay, why don't we move on? Tips for treating like canification of the genitals.
Yeah, most of the time I don't see that. Although I have had one patient where she was, as I think about it, scratching kind of that or rubbing that outside of the vulva. Most of the time I try to decrease friction in those areas. So I really try to make sure there's a good layer of, Vaseline in the jar. I'd start with that first. I'd really talk to them about not touching. And I would talk to them about sort of cotton underwear. Synthetics are actually made of fibers that are actually almost like fishing wire. So it can be sort of, even though it seems smooth, it can be harsh to the skin. Some topical corticosteroid, like just the 1% hydrocortisone. Then you can start thinking of other kinds of dressings. There's a Xerofoam gauze. I think it had bismuth in it now, and it's kind of this sticky gauze that just can stick onto the skin. So it's essentially like a dressing that is sort of protecting the skin from the environment or from any rubbing from the undergarments. That could be a thought. Generally, it's a lot of trial and error to get these people better, but you definitely can. It's just a lot of persistence and talking with them. I don't know if that helped a little.
How do you treat fissures and cracking that's bleeding and painful?
So it depends where it is. I do tend to like that Xeriform gauze, and I don't know if you have that on formulary, but the other thought would be something you could do a Telfa pad and cover it with Vaseline, just, have them put a huge coat of Vaseline on and then stick the Telfa pad there. Hopefully that's in the skin fold, so the Telfa will absorb some moisture. Zinc oxide paste, that's another thought. It's messy.
Some people say they don't want to use a moisturizer because it teaches, quote unquote, their skin to be dry and depend on the moisturizer. Is there any truth to this?
No, no truth at all. And the thing that happens is when that stratum corneum is disturbed, it also disturbs the layering of the skin oils so that they're not providing that kind of protective film barrier on top of the skin and kind of in between. The stratum corneum is made up of dead cells that are getting ready to shed, but they're kind of all covered with this lipid layer. It's not you don't want dry skin, period. And it's not conditioning your skin not to make oils. It doesn't do that.
Another question is, I have parents ask me all the time where their child got the tinea corporis, since they don't have any pets. I usually just tell them it's common and not always something we can determine specifically. Do you have any better answers or?
Well, it actually, in my slide, actually, let me go back because you still can see my screen. There are those anthropophilic infections. That's what we're seeing here. But that's actually from fungus that commonly is just sort of present on humans and then in certain conditions will start growing and spreading, right? So it doesn't have to be from an animal. And there's also dermatophytes that are from the soil, but that's very rare. But I think what you're telling the patient is fine.
Um, there was another question about fragrances. You said look for ingredients in fragrance-free products. What are we looking for?
Well, sometimes at the very end, they just say fragrance, so that's obvious. But there's a whole list of kind of fragrance chemicals. I think where it really applies is to patients who feel that they already are bothered by fragrance, and they can go online and kind of look at fragrance chemicals commonly used in products, and then just kind of carry those with you when they look. Because I don't have a list of all of those ingredients, and there's a lot of them, and they don't pop out necessarily as fragrance. That's why that when you go for baby products and the manufacturer is saying fragrance free, I tend to really believe that. Sensitive skin, probably there aren't any fragrance chemicals at all, especially since this article came out. I think hopefully some of the manufacturers kind of cleaned up what they were doing. But yeah, the patient would have to do a little bit of research, and generally they're motivated to if they're having a lot of problems with products.
In terms of, I guess, alternative moisturizers, what about coconut oil, shea butter, and beeswax for natural substitutes, or any other recommendations you have for non-synthetic products?
Yeah, that's a difficult one. I think the beeswax might be fine, but sometimes it has propolis in it. And propolis patients can be allergic to. So, I mean, for me, I was always trying to eliminate any potential allergens. So the things that I kind of stayed with was the petrolatum for sure, just because it's inexpensive. Some of those others, I would just have to do my due diligence just to make sure, that there weren't reports of allergen. Some people have done fine with aloe. Aloe's added to a lot of things, but I know you're trying to find a different base. I don't think I saw a lot of people with coconut issues, so that may be fine. But again, I would want to be going back to make sure there weren't any reports that I wasn't aware of.
Okay. And then there's another question that someone had heard that for curly hair, use ointment for scalp, and for straight hair, use a gel or solution that dries fast, won't leave hair limp and greasy like a cream or ointment would. Is that?
How interesting. So I've never been instructed in that way, nor come across with using different vehicles for different types of hair. I mean, that being said, anything that's more water-based is probably going to have some evaporation and it's not going to weigh the hair down. That was the purpose of, I think, the foams, whatever there is in that foam is so lightweight, it doesn't affect the hair. I would tend to think that I don't see a difference though for oily and curly. I really don't. It would depend on the hairstyle. So I don't think I can answer that question well. I'm sorry.
All right. I think that's most of the questions. Again, to the audience, Dr. Huber's slide deck will be coming out to you tomorrow or the next day, with again her appendix with lots of tips and references. I'm just wondering if there are any other questions that I might have missed.
And then my last comment is just that the next set of slides was on inner trigo. So that has a huge list of things that you can, print out and give to the patient that really talk about changing that moist environment. Because I saw a lot of patients that the practitioner had given them the right medicine, they had the right diagnosis, and the patients were still having trouble, and they were on oral antifungals kind of constantly. But what they really needed was to have the environment addressed, and then they could wind up clearing quite a bit. So I do take a look at those slides.
Okay, great. Thank you.
Thank you.
One other quick question. You'd mentioned prednisone bursts. Is there a standard regimen that you would use when you would be giving prednisone? So I think there was one person who had extensive
Yeah.
A rash on the legs, and you said you'd give prednisone.
Prednisone. Yeah. So, for me, I personally never gave anyone more than 40 milligrams of prednisone in the morning with food for a week. I didn't do 60 milligrams or 80 milligrams. When you use those high doses, you can have people have affected sleep. They're up all night because they're so agitated, or you can have people really irritable or really tired. And I did great with that regimen for the conditions that we've been discussing. I would do that for a week and then I would taper it. And my taper would depend on how long I think they really needed an oral corticosteroid. So I might go down to like 30 milligrams for 3 days, 20 milligrams for 3 days, 10 milligrams for 2 or something like that. But I kind of varied what I was doing. If I wanted them to have it a little bit longer, then, I might give them the 5 milligram pills and then go down by fives, 1 day or 1 or 2 days at like 35 milligrams and then 30, or, kind of change it. Yeah.
But 40 basically is the max, and then
for me that I found to be really good. And we're not talking about, now we have other treatments for, pemphigus and things like that, but typically 40 is what I stuck with and I had great results.
So that's kind of the standard for asthma and COPD flares.
Yeah.
Is 40 for 5 days. So it's similar.
It's similar. I'd like to do that.
Paper for the dermatologic issues.
Exactly. Poison oak, though. For poison oak, that's a good one that's a severe allergic contact dermatitis. So I did 40 milligrams for a week, and then I made sure that my taper extended for 2 more weeks. There's a tendency to stop too soon, and that whole inflammatory cascade has not been under control, and they'll just flare up. So you really want to have a total of 3 weeks of oral corticosteroids with that poison oak.
Poison ivy. Okay, there's a question about hydrocortisone 1%. Is it okay for infantile eczema on the face? What's the earliest age you can use cream on the face, and what about the ointment?
Interesting. I think you're trying to prevent sensitization. I used the 1% hydrocortisone ointment. I didn't have an age limit on that, although I'm not a pediatric dermatologist. I mean, I dealt with adult dermatology, but I don't think there's a restriction on that. The idea is very, very tiny amounts and not too often in application. But, back in the day when I was seeing kids as a resident, I mean, we used the 1% hydrocortisone ointment for little babies, just teeny tiny dabs, once or twice a day. And if it's in an area that's more occluded, like if the neck was kind of bent down and it's almost like a skin fold, maybe then just once a day. But I defer to the pediatric dermatologist for that.
But it sounds like one of the take-home points is ointment over cream as a
Yeah.
general. Yeah.
Yeah.
Okay. Okay. All right, we're 10 minutes over time. Again,
Thanks, Evan.
fantastic talk. We still have a fair number of our audience, about half. We had over 50 audience members, so
Okay,
clearly
wow.
great interest in skin conditions are a huge problem, as I think we all know. And there's a wide variety of them. But I think with that, I think we've answered most of the questions. If there aren't
Thank
any
you.
other questions, thank you again, Dr. Huber, for a fantastic talk.
Thank
Thanks
you
again
so
to
much.
the audience and Cherokee Health Systems for hosting. If there are other topics, please submit them to Kristen Talbot for other talks that you want, or if you want similar talks from Dr. Huber and her colleagues in dermatology. Thanks again, everybody, and have a good rest of your day.
Thank you so much. Bye.
Bye-bye.